Our third presentation is titled Motion Capture slash Gait Analysis. It's going to be presented by Dr. Felix Cheung, MD. So a brief introduction, gait analysis can be used to provide objective data regarding how we walk before and after specific medical interventions. Traditional techniques have involved visual video analysis and marker systems. The intensive labor requirements from visual analysis and precision errors from marker placements have made these techniques difficult to use. Dr. Cheung is going to talk about markerless motion analysis. Dr. Felix Cheung, MD, is an assistant professor of orthopedic oncology at the Jones C. Edwards School of Medicine at Marshall University. After obtaining his medical degree at the University of Virginia, he completed his residency in orthopedic surgery at West Virginia University and finished a fellowship in orthopedic oncology at Harvard Medical School. In addition to his clinical practice, his interests include medical student teaching techniques, patient outcome analysis, gait analysis, and pathologic fracture prevention. He lives in Huntington with his wife and daughter. Without further ado, here is Dr. Cheung.
Thank you, Venkat. All right. Is the microphone working? Can you guys hear me? Okay. And is there a way to turn off these overhead lights here?
No, we're recording it.
You're recording it? So if it hit off, they'll be bad, huh?
Yes, because we'll be.
All right. I believe you. All right. Anyways, thank you for inviting me to speak to you guys today. As Venkat spoke, I said that I am a medical doctor, and so I am always in awe when I enter a room full of PhDs. And my father used to always joke that all PhDs want to be called doctor, but the reality is all MDs want to be called professor. So today, I am indulging in my title as professor today, instead of having to see those pesky patients all the time. But Tony asked me to talk a little bit about motion capture and gait analysis and what we're doing in the Viz Lab as a result of the investment that they've made in this particular unit. Overview, we'll go over what is gait analysis. We'll talk about the ways that you can do motion analysis and gait analysis. And we'll go on to some of the medical applications that I am using to try to figure out some deep questions that we have about our medical issues. So in general, motion capture and gait analysis is essentially the quantification of human locomotion. And we take all the great complexities of motion and try to break it down into the basic kinematics. That is the angles of the joints, pelvic tilt and obliquity, and including the dynamics of the joint reactive forces when you push against the ground. There are many uses of this. You can study normal folks, like you can study what they do in sports, how people run. You can use it for video games. And here, if you can see better, this is Tiger Woods dressed up in a whole bunch of little markers, and they're trying to mirror his golf swing for his latest video game, Tiger Woods Meets the Masters, or something like that. Or you can use it to study pathologic problems, such as children with cerebral palsy, and people who have neurologic problems, and basal cell type of things. And also you can study what happens to folks after they survive an injury. There are several methods for doing it. You know, the least technological one is to what we call eyeballing, where somebody walks across the stage and the gray-haired professor looks at him and says, Trendelenburg gait, 3 degrees off to the right. Someone put that down, and we'll have to do this. And so this was very good when you have a gray-haired professor in there who's seen a zillion of these and can say, one way or the other. But I don't have that many gray hairs yet. And so I found that to be fairly not very objective. It'd just be like, yeah, it looks like they're walking okay, but I'm not really too sure. It gives you a good gestalt, but it doesn't really tell you exactly how they're doing it every moment. Then in the 1900s, they decided to use strobe lighting and photography to find this, where you have a model walk across the stage and strobe light it and capture it all in one film. And this was really fascinating for the 1900s. But this was very cumbersome, labor intensive, and I guess you had to be naked to walk across the stage back then too. So I don't really know why they did it that way. Then we moved on to video cameras. In the 1970s and 80s, people started using video cameras where you had someone walk on a treadmill and you recorded them with a video camera in 1 or 2 views. And then, I used to do this when I was in medical school, we'd actually have to put it on an old CRT screen. Now imagine hitting pause on an old VHS tape, because this is before you had digital, right? You'd pause on a VHS tape, and everything gets all fuzzy, and then you had to guess where the hip, knee, and foot were so that you can measure it, and then you'd advance it 1 frame which is like 1/60th of a second, and then do it again. And so to do 1 whole second of knowledge, it took you like 60 frames. You know, they certainly exacted their pound of flesh out of me when I was a student back then to do this, and it just took a really long time. But this was the best we had. Now we move into the late 80s and early 90s, where we've discovered a marker system, a passive marker system, where we would then take reflective balls and place them in certain anatomic structures in the human body, and then allow you to walk across a stage. And they would have cameras, CCDs really, that would capture just light, not pictures, but just light. And then the cameras would be about 6 of them in a round, so then they could sort of use computation to figure out where each marker was in space. You told the computer what the marker represented, say the greater trochanter of the hip or the medial epicondyle of a joint or something like that. And that's how they sort of captured where things were. This was a revolution, and Vicon is the company that does it. And we, in fact, have several Vicon systems here on campus. One's owned by the athletic department. One is owned by the Department of Kinesiology. And this was the gold standard for many, many years. But there were problems with this. Number one, in larger people, it was very difficult to find the bony landmarks, exactly where they were. So marker placement became difficult. Number two, if you're studying, as what I was doing, children with cerebral palsy, those kids aren't going to stay still long enough for you to tape something on their leg. And then when they see something on their leg, the first thing they want to do is take it off. And so it's very difficult to try to get the markers to stay not only in the right place, but also keep them on. And then if their skin moved, you know, you would have them move around, and it wasn't very good. And you'd have to do multiple trials. This was also very cumbersome and not very elegant. And I did my fair share of these as well. So we move into the 2011s. Really 2009, right? When did we get this? 2009? 10?
2009. Yeah.
2009. Moving to 2009, where someone's figured out a way to do this without any markers. The Markerless System. It's designed by Organic Motion. And essentially, there's a white box and 14 cameras that go around this thing so that it can capture every piece of 3D information you have. And it uses your body's shadows to determine where things are. And it uses a very complex algorithm. When your shadow looks one way on one camera, they assume it looks a different way at another camera, matches it up, and renders you 3-dimensionally. And this is how we use it to capture and recreate motion. Think of the advantages of this, right? No longer do you have to tell people to put all these markers on, wear a skin-tight black suit, because I don't know about you, but I don't think the public wants to see me in a skin-tight black suit very often. So this has been very easy and elegant to use. And we think the data will show that it is just as accurate, if not more accurate, than the marker system, because it's your own body that it's using to reference things. It's not like one grad student puts on a marker here and another grad student puts it somewhere else. You have intra-error, but if not, then you don't have to worry about it. So it's most convenient, but we're still determining whether the precision is good enough, whether the accuracy is good enough. Okay. So this is sort of an example of what it would look like when captured. This is, Justin helped me capture this one here. Oh, why won't it play? There we go. And this is what it looks like with the Markerless System as replicated by a skeleton. You can see that it looks like a skeleton. It knows my size. And here we can actually do all those gait analysis things we're talking about. Right knee flexion, hip flexion, ankle flexion, the pelvic bend. All these things are measurable in real time as we go across the stage. I'm just walking back and forth. And this seems to correlate fairly well with what we actually see on the screen. Are there any questions about this part? I'm going to go into the applications next.
How do you superimpose a skeleton on it?
The skeleton, oh, that's a great question. So the program actually, you can actually choose a variety of avatars for you to sort of do. So you can choose like, you know, a skeleton, you can choose a stick figure, you can choose Brad Pitt, anybody you want, and you can superimpose it on there. I should have done Brad Pitt. Why didn't you do Brad Pitt for me, Justin? That's what I should have done. That's what I should have done. Any other questions right now? All right. So I am an orthopedic oncologist by trade. I operate on people who have cancer in their bones, whether it's metastatic or primary bone cancer. And so one of the major emphases in my field is not only trying to get rid of the cancer, but say if you cut out a large portion of your thigh bone or your femur, how do you replace it? And how do you reconstruct it in a way that the person can actually continue to use their limb in a fairly normal way? And that's called limb salvage. Why is this an issue? Well, up into the 1970s, aggressive bone tumors were treated purely with amputation. We said, bone tumor, we have no way of saving your limb. Let's just cut it off. At least we'll save your life. So if you had a cancer like this person has in their hip, you got a hip dysarticulation, and you had some crazy prosthesis to try to replicate it, which never fit very well and didn't work very well at all either. Okay? Unfortunately, after we studied this for a while, we learned that the ones that we amputated didn't actually live any longer than the ones we did not amputate. Like some patients chose not to have amputation, and they lived the same. So we're like, why are we cutting people's legs off if they're going to die anyways? You know, let them die with their leg. So we started just cutting out the tumor, because none of us really wanted to leave the tumor in there and let it fungate through the skin and smell bad, and it wasn't very good on dates. So, you know, it was a problem. So we cut out the tumor, and we said, well, let's just replace it with something, some placeholder until they die. We only need this to last a couple years because they're going to die. And so that's what we did. We replaced, you can't see it here, but this patient has a large chondrosarcoma in the proximal tibia, and we replaced it with a gigantic metal prosthesis after we'd cut out everything and closed the skin over it. And this was good because the patients still died in about 2 years, but at least they got the use of their leg. We saved their limb for the period of time that they were alive, and they didn't die any sooner, and certainly they didn't have any higher rate of local recurrence. So this was a good thing. But we got better at treating the disease. And now we can get over 70% 5-year survivorship of these patients with chemotherapy, radiation, or some combination of the two. And so now we have other issues to deal with, right? Because now we've saved their leg, but at what cost? In other words, how good were these implants we were putting in? Are they pain-free? Are they doing well? So we now have to not only look at how much longer we can make the patient live, but also what is the outcome satisfaction of the patient? Are they happy with their leg? Are they happy with their prosthesis? In other words, we are starting to care not only about whether the patient lives or dies, but whether they have a good quality of life when we're done. Okay? And so the various reconstructions that have been done through the years include nothing. And here's an x-ray of a patient who had cancer in the proximal hip, and now we just sort of cut off that portion and didn't replace it with anything. This gives you usually the best oncologic outcome and the least amount of complications like infection or things like that, but you don't have very great function. And this is called a girdle stone, and you only get about 2/3 of the function you did before you had the surgery. We can fill it with cadaver bone, where we replace your normal bone with cadaver bone, and about the first half an inch or so will heal into the native body, and then that's sort of how it stays together, and you can walk with it. This is pretty good. They usually fail in about 10 to 15 years because of fatigue for the rest of the bone that's not biologic and will eventually fatigue over time. And they also have a high fracture rate, non-union rate, infection rate. It's not ideal, but it works. But the modern technique is to use mega prostheses, which are gigantic total joint replacements. This is a distal femur and joint replacement here. We're using metal and plastic to fill the void in functionality. The word we use is, who cares about biology? We've got technology to solve our problems here. But we still have a failure rate of about 15% with infection and hardware failure. I mean, it is just plastic, and a lot of kids have these diseases, so when they put them in when they're 15, by the time they're 30, the lifespan of this prosthesis is over. We have to go back in there and redo it. Here's another example of she was 18 at the time, had a proximal humerus osteosarcoma. We cut it out, replace it with a huge mega prosthesis. And then the last thing we can do is, rather than save the limb, we can actually just go back to amputation. This was a 26-year-old soccer coach from the Charleston area who was diagnosed with osteosarcoma in the distal femur. I had every intention of trying to save his limb, but intraoperatively we discovered that the tumor had entwined his entire neurovascular bundle, which means that would have to come out as well. Now, if you don't have any sensation in your leg, you don't have any blood supply to your leg, it's probably not a very good leg to save. So we ended up amputating him at the time of the procedure, and that is his post-op. But what got me thinking about outcomes was, if I had done that mega prosthesis that I had spoken about earlier, well, I would have had to keep him on crutches for 8 weeks while all the soft tissues and the skin healed and the bone healed into the prosthesis. Then he'd undergo a very lengthy rehabilitation to strengthen up his quadriceps again and his hamstrings and get everything going. And then maybe he'd be able to walk fairly normally after 8 months of good rehab. This guy was back on the soccer field in 2 weeks. His wounds were healed up in 2 weeks. He had gotten his external prosthesis and was walking around and doing great. And so I was like, well, maybe there's some people we shouldn't be saving limbs on. Maybe for the very active people who wants to play soccer, maybe those are the people we shouldn't. And so that's where I got interested in gait analysis again after my horrible experience with children with cerebral palsy and this, is that maybe we want to know how well they're doing, whether we can get them to walking normal again. So we are currently enrolling patients in a IRB-approved study where we give them outcomes measures, a SF-36 and a DASH score and a WOMAC score. These are validated outcomes measures of how the patients are doing for their upper extremity, lower extremity, and overall well-being. And then we run them through the gait analysis lab to see how well they walk with their huge mega prosthesis that I've given them, or with their artificial limb that the prosthesis has given them. And we'll see how well they do. And you can see why a markerless system is the ideal system for this. Because if you have a patient who is a cancer survivor and has like limb issues, skin healing issues or whatever, you don't want them to wear a lot of clothes and be very cumbersome in terms of getting them into a marker. You just want to be able to run them through the system. And so I think that's what we're doing. We're still in the preliminary stages of this, but we sort of gamma tested it with some normal people. And it turns out that it only takes about 10 to 15 minutes to actually do a whole trial of as many walks as you want, back and forth. With a markered system, it's literally an hour to put everything on. Then maybe a couple walks will take you 10, 15 minutes to do that. And then you have to take everything off. So much more convenient for the patient population. So now we're moving from subjects, which are usually underpaid graduate students, to patients who are volunteering their time and doing this and don't want to be messed around with if they have real disease somewhere along the line. The other hat that I wear in the Department of Orthopedics is I do quite a few joint replacement surgeries, and I'm very interested in the biomechanics of joint replacements. And there's been a development of a new kind of joint replacement that has the potential to, I think, really change the way we view the functionality of joint replacements in the future. And it's called a Makoplasty. And we'll go over a little bit in the test. Now, I know I'm talking to PhDs, not MDs, so we'll go over some basic medical stuff just to get everyone up to speed. So osteoarthritis is the degeneration of the bearing surface of a joint, that is the articular cartilage, that leads to increased friction with movement and therefore a release of painful cytokines and inflammation that causes pain. Okay, so this is a mechanical problem. It's a higher coefficient of friction causing release of cytokines. Okay, in the knee, osteoarthritis typically follows a pattern where it starts off in the medial or inside portion of the knee, spreads up to the patellofemoral compartment or underneath the kneecap, and then only end stage do we get all the way over here to the lateral portion of the knee. Okay, so there's almost a reliable pattern of disease, but if you can arrest it at an earlier stage, it doesn't always progress to the end. Okay? Conservative treatment of this includes injections, medicines, physical therapy. And traditionally, surgical options include total knee replacements or partial knee replacements, where we replace the diseased cartilage in both the medial, the lateral, and the patellofemoral compartment and replace it with metal and plastic. Now, if we can catch it early where you only have disease on one side of the knee, then we can only replace that one side. Okay? And that has certain advantages and disadvantages. The beauty of a total knee replacement is this has been done since the 1960s. It's got a great track record, great longevity of about 15 to 20 years. It's great. But the problem is there is a slower recovery. It takes about 3 months for you to recover back so that you're about walking normal again after your surgery. And then the techniques to replace them often require sacrificing the anterior cruciate ligament and the posterior cruciate ligament. And sure, the stability of the knee is one thing, but the real thing is that each of these ligaments contain proprioceptive nerve endings, which tell you where the knee is in space and helps your other muscles, your hamstrings and your quadriceps, control where your knee is in space. Absent of these two ligaments, your knee does not feel normal. So while I do total knee replacements all the time and my patients come back and say, wow, this feels great, it feels like my knee is numb, I don't feel anything there, but thank you, doctor, for getting rid of my pain, but it just doesn't feel great. I mean, it doesn't feel normal, but at least I got rid of my pain. Now, partial knee replacements, you can preserve the ACL and the PCL and cut less bone away. And subjectively, patients who have had both partial and total knee replacements on different knees prefer the partial knee replacement. They think it's better than their total knee replacement, mainly because they can feel it. But these are very warm and fuzzy subjective criteria. And additionally, partial knee replacements are much more difficult to place accurately. If you are doing a total knee replacement, you get to throw the baby out with the bathwater. You just make all the cuts you want, and then you sort of use a jig to guide things up, and you put it in. It's easy because you cut everything open. But in a partial, if you're just doing part of it, if you damage the other compartments, well, you kind of screwed the pooch. You kind of, you didn't mean to do that. So you can only look at part of it, and so it makes it much more difficult to put in there. And so this is sort of where we come into this idea of a Makoplasty, and this is part of cyber infrastructure that we're doing over at the school. But what we do is we'll take a CT scan of your knee and then use computers in order to create a three-dimensional model of your knee. Then we will map the partial knee replacement to this model, okay, electronically at first. Okay? Then we will go into the OR, make an incision into the knee, and then this is a haptic-controlled robot. This was originally designed to clean bathrooms, but I don't tell my patients that. And what it is there's haptic control. So in other words, there's a high-speed burr at the end here, which will then burr out the bare minimum bone needed in order to do this knee replacement, this partial knee replacement. And I'm the surgeon. I'm holding it with my finger to start and stop it. And it only allows me to go where I'm allowed to go. In other words, if I try to go beyond the realm of where the knee should be, it beeps and it actually gives me force feedback to tell me to stop. And if I overpower it, it stops the burr. So I cannot injure the patient or cut any more bone than I need to. So there is indeed precision sculpting of this thing. And you can sort of see where the computer model is down here telling him where to go. And you sort of go over here and do that. You can do this for the patellofemoral compartment as well. You notice how it's sort of going up there. And just sort of you do that. Magically, that happens. And then once you do that, you can actually place in your tibial side, the plastic part, and then also place the metal components to make up the difference. And although the FDA has only approved us to do 2, I don't see why you couldn't do 3 and still preserve your ACL and PCL and do that. But none of us are going to do anything the FDA doesn't tell us to do right now, so that's for a future talk. Right now, what we're doing is talking about robotically partial knee replacements. So what we do here is, I really do think there's a significant advantage that's not just subjective from our patients, that these knees are better. And one way to show that will be to see how long it takes for these patients to return back to normal gait. If there is indeed detectable differences in gait between a partial knee replacement patient and a normal replacement, and a normal knee, and whether there's a difference between that and a total knee replacement. From talking to my patients, I know there's a difference, because a partial knee replacement patient comes back saying, my knee feels like I was 20 years old again. Can you do this for the rest of my body? And I tell them, no, I can't. I am sorry, okay? I only operate in hips and knees, that's it, right? But if you do a total knee replacement on them, they come back saying, thank you, doc, for getting rid of my pain. My knee feels numb, it feels a little strange. Sometimes I forget where it is, but thanks for getting rid of the pain. But with my partials, they still complain of some pain. I mean, they still have sensation in their leg, but it feels like they were 20 again. And so that's what we're doing with this markerless system. Again, immediate post-op, limited mobility patients, you're going to be able to have this sort of ease of use for this markerless system. And currently what we're doing is trying to validate the system if it's accurate enough and precise enough. And this is an image that Justin was gracious enough to send to me. This is actually Justin here. And he's walking across the stage, and we set up one of those old cameras, although I think you used a non-VHS version, right? You used a digital this time. And we were able to measure the knee angle when he was walking, and we compared it to what it looked like exactly at that time. And we came pretty close. It wasn't exact, but as we refine our technique, we should be able to get these. And once we validate the system, then it will be fairly accurate, and hopefully we'll really be able to get going with a lot of these particular things.
It looks like Brad Pitt, sort of.
Maybe. So if you guys have, whoa, what's going on here? Anyways. If you guys have any questions or anything like that, I'm part of the orthopedic oncology service, and you can reach me at my email, which I placed on this thing. It's chungf@marshall.edu. If you have any questions about this presentation that you did not want to share with 25, 30 of your favorite friends out here, okay? Thank you very much for your time.
So we have a couple of minutes for questions.
I'd like to ask, is the failure after a procedure here from epoxy failing in 15 years, or is it the actual polymer that degrades?
So So
The
there,
action piece.
yeah, so there are two modes of main modes of failure for these megaprostheses after time. One is that the polyethylene liner, which is just plastic, eventually wears out, and the components get a little loose, so you have to replace the plastic. That's not that big a deal. There is another material, PMMA, that we use to cement the stem to the bone, and over time, the bone-cement interface degrades. And that's what causes loosening, and that's when you have to replace everything out the thing. So there are two modes of failure: either the plastic fails, or the bone cement, which is plexiglass, fails at the bone plexiglass interface. And so that's the metaphor. There are ways that we're trying to prevent that. For example, we're trying to develop a way to get it so that the bone directly grows into the metal. In which case, if it grows in the metal, then there'll be no shearing, no loss, and that we're putting those in our younger patients right now. In Europe, they're starting to coat their prostheses with silver so that the silver ions leach into the joint space. As we know, silver is a bacteriostatic material, and so our infection rates would theoretically be lower in that case. That's another method of failure where an infection causes things to loosen as well. So silver seems to work, and in Europe and England, they seem to have about a third the infection rate we do in America once they started using this prosthesis over there. But nobody knows the long-term effects of having silver ions for like 30, 40 years in your body either. So we're a little less risk adverse. We have better lawyers in this country, I guess.
Okay, thank you.
So other questions? Before I turn to Tony, I would please join me thanking all the excellent speakers for the session.
Thank you.